I was just reflecting really on my life in work. I'm in my 39th year of employment, and when I first started, we did everything on carbonated paper. All case notes were handwritten, and today I can't be separated from my BlackBerry or my iPad. I wouldn't be able to do my job without it. And I think it's just to make a point that Stephen's already made far more eloquently than I, that technology is a significant part of the way that we live our lives today. Our lifestyles are changing, society is becoming faster paced, quicker, we lead busier lives, we're constantly connected. Not for me, but 55% of us look at our phones within 15 minutes of waking. And 81% of the population now use a smartphone, and I think that number's increasing as well. So that sets some of the context. I'll say a little bit more about technology and science and how that's changing shortly. But I want to just address this point from the white paper, and this came out of a conversation I had with Alison and Paul a few weeks ago now. And I want to argue this morning that there are 5 influences on the quality and safety of health and care services. And I'm going to extend this argument to where technology is used in the delivery of health and care, however it's used. And my argument is that of these 5 influences, what commissioners do and how they set out their expectations of quality, what the standards are, and therefore what people then go on to buy, to purchase, to procure, is absolutely critical in relation to the standards that providers use. Second influence is that which providers bring to bear on the way that quality and safety is taken forward, again including technology here. So if you work for a large organisation which has a board, what's the standard that your board sets, and how does that board prioritise the issues around quality and safety and the use of technology and how technology can promote quality and safety? The board often, and the executive leadership will often set the culture and expectations in an organisation and begin to shape that. What do those staff, and critically professionals, what do the staff in an organisation, how do they shape and influence quality standards? A number of people in the room will be qualified clinicians. You'll be registered with a registration body. And in signing up to your registration, you'll make a personal commitment to uphold quality standards, whether you're a doctor, a nurse, a physiotherapist, an occupational therapist, a social worker. You'll be actually agreeing to meet a given set of standards. I'll come back to this in a second. The fourth influence on quality and safety is what do regulators do and how they do it. So that, I mean me and my colleagues in CQC, but I also mean the professional regulators. I will say a little bit more about this and why that's an important relationship shortly. And then the fifth influence is expectations and the voice of people that are using services. And the reason I've set this argument out today is that I think there's a danger in an over-reliance on regulation as a way to actually begin to take forward the debate about technology in health and care. All 5 of those influences need to be present and working together if sustainable improvements in the quality and safety of services as delivered through technology channels is to be maintained. So, what about CQC? What is it that we've been doing and how have we been going about doing some of this work? Well, as you can read on this slide, we've done 40 inspections of registered providers over this past 12-month period, effectively. And we've published 28 of those reports. And as you can see from the slide, we've actually taken enforcement action in relation to a number. And I'll say a little bit about what we've found. But in order to do this work, I touched on professional regulators earlier. We've had to undertake some quite important work with other regulators, the medicines regulator, MHRA, and also the professional regulators, particularly the GMC, but also the NMC, and the pharmaceutical regulator as well, because some of the issues that we found in our inspections are not just about access to general practice, they're about access to pharmaceutical services. And as a consequence of this work, we now meet regularly with professional regulators and other regulators, including the Scottish and Welsh regulators. Our jurisdiction is England only, but many of these issues, as we've found, go across international boundaries. And what we've been doing in these cross-regulatory forums is beginning to look at some of the issues around the regulatory landscape for online primary care services in particular, where we've had to draw on the expertise and knowledge both across the UK but across all types of regulators. We're now beginning to establish formal relationships around our inspection and registration activity with these organisations. So we signed at the end of September a new Memorandum of Understanding with the MHRA where we can underpin what is a very strong operational relationship. We already had an MOU with MHRA, but in the light of the experience that we've gained in terms of the inspections. So what is it that we've found in these inspections? Well, there have been 5 key themes which have emerged from the work that we've undertaken over the past 12 months or so. We wrote round to all providers a few weeks ago and set out some of these key themes. That's a letter which is public, so if you've not seen it, I would encourage you to have a look at it. And we also published some advice to service users and their families about the things to look for when choosing an online healthcare service. The reason we did this is some of these services are paid for services, and there is an issue about, as a regulator, is caveat emptor or buyer beware sufficient, or do we need to actually flag through our work information about the quality and safety of these services so people can make informed decisions in relation to these services. So what were some of the 5 themes? Well, a first theme we found was how do services ascertain patient identity? So I could go on some of these websites now, I could actually pay my money, and technically I could be prescribed opiates. That could be done without any knowledge of what my medical history is or whatever medication I'm currently receiving. Second issue we raised was around consent. What is the process by which people can secure consent, i.e. the clinician or the prescriber secure the consent of the individual? And going back to the identity issue, how do you know that that consent is being given? We've come across situations where using digital channels, children have purported to be their parents, use their parents' credit cards and purchase some quite significant medication. So what is the process of consent? Similar issues in relation to capacity. How do we secure people are able to consciously make decisions about the treatment that they wish to access? The fourth issue was around communication with a registered GP. Some examples of digital channels being available through the NHS, well, that's relatively straightforward for the check of a person's own health record. But how do these services feed back to yours and my GP that we've actually accessed services, been prescribed treatment or medication? And then the fifth issue which comes out of this is in relation to a range of safeguarding issues which exist in an online environment, which draw together some of these issues around identity, consent and capacity, etc. So as I say, we've published some of this guidance and advice, so that's available for people to draw on. We're also establishing a forum with providers. The first one of these takes place on the 26th of October. And following that meeting, we'll publish some further guidance later in the autumn in relation to how we intend to work with the sector. And just before Christmas, by the end of this calendar year, we'll publish a report, an end of programme report on what we've learned from all 40 of these inspections we've done of digital providers. Now, one of the things I'd want to say about the work we've done so far, the majority of organisations that have registered with us are really using a digital channel to access a pretty traditional service. So instead of going and ringing your GP, you may be speaking to them on the telephone or turning up at the surgery and having your 10-minute consultation with your GP. A lot of what we've found in this first round of inspections has been, instead of doing that, you go in through a digital channel, through an app, and you still end up speaking to a GP. And very often the issue that we've raised in these inspections is not the fact that you've gone through a digital channel. It's been the issue of the quality and safety of the general practice that you receive. We've had difficulty in some cases identifying where the general practitioners are and where they're registered, so cases where using access which is available in England. The GP that has been accessed has not been in this country but has been in Europe somewhere, and those GPs may or may not be registered with the GMC, which raises issues in relation to identity, consent, etc., etc. But I want to draw a distinction now between that work and some of the future challenges for regulation and the thinking that we're doing. So it's already the case that in some conditions, artificial intelligence is a more reliable diagnostic technique than human diagnosis, i.e. going to see your GP. And so this goes beyond digitally as a route, a channel by which you consult your GP into it's not only a channel within which you get access to the service, but it is the means by which the diagnosis is made. So how and who vouches for and verifies the quality and safety of the diagnosis that's given? If that diagnosis then also results in treatment being prescribed, how is the security and safety of that taken forward? And increasingly, we're going to see digital not just as a channel by which you access a traditional service, but we're going to see this developing as this will be the treatment that you receive. That has tremendous implications, not just for the way that we work, but also the way that professional regulators work. I saw from the Health Service Journal as I travelled up from London this morning that there's a pause been put on an app that's being used in the northeast of England, which has 500,000 patients currently signed up to it, which was literally about the quality and safety of the advice which is available on at the end of that app, which rather makes a point. So what we're beginning to do is think hard about those issues and taking forward that work with key national stakeholders to develop practice guidance for these new types of service. So this is how we're moving forward, and as you can see, we've got three aspects to this work. First is this important work around horizon scanning. I think this goes to the point that Stephen was making about how do we keep track with the emergent technologies and the speed at which this technology is coming forward, not so we can get in the way with it, in the way of it. One of our key strategic objectives is to actually take the opportunities by innovation, work alongside them in real time, so that we're not holding up innovation as we think through what the implications of regulation are for the work that we do. So we've been developing our approach and capacity and capability so we can actually focus and concentrate on the way that technology is going to increasingly play a role. We've got the personalisation of medicine through genomics. I think many of you here and many of the exhibitions will be around telemedicine and telecare and the role of e-health. I've already mentioned artificial intelligence and machine learning, which will underpin clinical decisions. For those of you that have looked at how Japan is responding to the future challenges of an ageing society over there, you'll know that they're now using robots in care homes. There have been robots used to reduce loneliness and isolation in older people living in their own homes. And only last week in our State of Care report, one of the examples of good practice that we used is a care home which has been using a listening device to actually assure themselves around care during the night. Purpose of this is instead of care staff going in and opening a resident's door and closing that with all the disruption that that brings, using listening devices which recognise a sound above the normal sleeping sounds. And lo and behold, what has happened there is that they've had fewer falls in that home because if somebody gets up during the night to use the bathroom, they're not falling and tripping. There's assistance being available. But they've gone even further than that. One of the issues that they now address is what they call a wide awake club, which is for a number of individuals who are awake during the night. And you'll know many older people have quite irregular sleeping patterns, that instead of people being left in their own rooms, potentially wandering, there's some constructive time where people will share a cup of tea and share some conversation. So a very simple device. Most of us that have had babies have probably had baby listening devices, and that's effectively what's being used here. Very simple technology leading to reductions in falling injuries which arise as a consequence. So this is not necessarily the most sophisticated technology, but it is technology being applied in a very practical way, leading to improvements. So we'll continue to take forward this work, as I say, looking at horizon scanning, developing our approach, our capacity and capability, and continuing to review the landscape, and particularly the development of new technologies and how they can make a contribution to care. And we'll do that by engaging stakeholders and innovators as we develop this work over this next period of time. So thanks very much for listening.